We have to give. Good morning, everyone. I'd like to welcome you to the UH Health Services Research Center Distinguished Speaker Series. We have a couple of housekeeping points I'd like to remind everyone of, and then I will be pleased to introduce our speaker. So first, the webinar is being recorded and it will be available to view from the UH Research and Education Institute website. Please mute your microphones throughout the presentation. If you need technical assistance, contact Nicole Bollinger or Abigail Zona. They are on the call. You can message them, or if you need to email them, Nicole Bollinger or Abby Zona, to get back. If you want to ask questions, please type them into the chat, and we'll have a Q&A after the talk. The questions can be seen by all attendees, so you do have the option to submit them anonymously if you prefer. If you are one of the invitees to the meet and greet after the presentation, please just stay on the Zoom after the Q&A part. And so on that note, it is my pleasure today to introduce Dr. Victor M. Montori, who is the Robert H. and Susan M. Rewalt Professor of Medicine at Mayo Clinic. Dr. Montori has distinguished himself as an endocrinologist, a health services researcher, and a healthcare activist. Dr. Montori is the author of more than 750 peer-reviewed publications and is among the most cited researchers in clinical medicine and in social science. He is a recognized expert in evidence-based medicine, shared decision-making, and minimally disruptive medicine. He works in Rochester, Minnesota at Mayo Clinic's Knowledge and Evaluation Research Unit to advance person-centered care for patients with diabetes and other chronic conditions. Dr. Montori is also the author of the book, Why We Revolt. Why We Revolt describes what is wrong with industrial healthcare, how it has corrupted its mission, and how it has stopped caring. In it, he proposes a revolution of compassion and solidarity and unhurried conversations and careful and kind care. He proposes a path to healthcare delivery that rejects industrialization and instead fosters healing relationships between patients and clinicians. His presentation today is entitled The Clinical Encounter from Black Box to Research Frontier. Thank you, Dr. Montori.
Thank you, Dr. Teal, and thanks everyone for being here today for this honor for me which is to present this distinguished lectureship series. Please, can you verify that you can see my presentation? Okay. No, for some reason I can't. There we go. So this first slide has my email, and I invite you to contact me if for some reason we don't get to your questions or new insights or thoughts occur after the session is over, which is what usually happens to me when I attend these things. So please, I invite you to use this email and contact me after the presentation if that becomes necessary. I don't have any financial conflicts. I receive my salary from the Mayo Clinic as a clinician. I'm an endocrinologist there. And I'm actually coming to you from the care unit, which is our research unit, which this year is turning 20 years old. So we're very proud of it. The care unit from the beginning decided not to take any funding from any for-profit corporation. And so we don't have any disclosures from there either. As Dr. Teal mentioned, I co-founder and chair of the board of the Patient Revolution, but I don't derive any income from that work. And also the proceeds from the book go to the Patient Revolution organization, so they don't come to me either. Today, I'm going to try to convince you of these four things, and I'm planning to be successful, but I'm looking forward to any questions or pushback that might occur. The first one is that care is at the core of healthcare, and you think, well, that's pretty obvious. Not for any observer of our healthcare system, unfortunately. Second is that a lot of care, not all of it, but a lot of care happens in clinical encounters. But despite the centrality of the clinical encounter, I would put forward that it remains for most of healthcare delivery research, health services research, or healthcare clinical research as a whole, as a black box in which something happens. And I think we should not leave it as a black box, but in fact should be our research frontier. Let's start by trying to describe the healthcare system in which we work. It is one that I believe is obsessed with this notion that we must deliver the right care to the right patient at the right time and with the right people and so forth. This notion that there is a right answer is furthered by practice guidelines that make strong recommendations for certain activities, quality parameters that indicate those activities must occur. And any deviation from that, at least initially, characterizes a defect in the quality of the work that we do. And so then the task is to get the right answer and to make sure that the right patient gets it, which blurs the line of who is that we're responding to and assumes that people have one condition for which that answer is the right one. Unfortunately, we live in a very, very complicated and increasingly complex world in which people don't come neatly with one condition or disease that for which we have a silver bullet that, if delivered properly, will result in solution. But rather, like this graph, we live increasingly in the world, particularly in adult outpatient medicine, which is where I work, in a world in which the most common patient shows up with at least one, if not more, ongoing chronic conditions. Also, as people, as we move towards lower socioeconomic situations or more diverse socioeconomic situations, these chronic conditions accrue at a faster clip and earlier in life and with more mental health in addition to physical health challenges, which also increases the complexity of the response that they need when they seek care. So the notion of a right answer for these patients becomes a bit problematic. And so the question that we face is this, how might we respond not to this condition, not to this disease, but to the problematic human situation that the patient brings to us, a situation that increasingly we recognize includes not just the biological aspects of those conditions, but the socioeconomic and the relational aspects that the patient brings to the table that are contributing to that problematic situation that is affecting their health. And yet, when we face those patients, we unfortunately see them too fast, see them perhaps only as a test result. If you're a specialist like me, you may see it only through the lens of the condition and, of course, of the specialty that one has. You may see it as a statistic. If you're doing population health and you have a program to improve general outcomes, this patient might be showing up in your list as someone who is not well controlled and needs additional attention. Or you may fall under the illusion that because you've read the medical record of the patient that you've met her. This is a picture of Maria Luisa. You could not tell because it's a bit blurry. And this is how we often are asked to see patients, just as a blur. Here's a better picture of Maria Luisa taken by her granddaughter at her home. And as you appreciate her situation, you can see that in front of her, there is a large number of tablets and pills that she has to administer to herself. And yet, despite that large volume of healthcare services and products, if you explore her expression, you might come up with a number of ideas of what she might be feeling, but certainly healthy is not one of them. How is it that she got all those pills? Well, because in order to find the right answer and sort of take care of her, even if we only see her as a blur, we must focus on the biology of what she brings, what she has in common with other people like her, diabetes or kidney failure or hypertension. But if we only respond to her biology, we're providing care for people like Maria Luisa, but that is not the job. The job is to care for Maria Luisa. And for that, we not only have to attend to her biology, but we need to, which she has in common with other people, but we must attend to her biography, what makes her peculiar, particular, or special. That biography, where she's been, where she comes from, what her history has been, is clearly putting a lens, putting a painting coloring how she's experiencing her condition today. Her current conditions are affecting the safety and potential efficacy and feasibility of tests and treatments that we might be considering for her. And her expectations about the future, her goals and priorities should probably be supporting what we do. If not, our care will be generic. Now, as people like Maria Luisa accumulate chronic conditions, we are asking her, when she comes to our healthcare systems, to visit multiple parts of our organization, multiple buildings, come through different doors, attend different parts of our delivery system, which then places demands on her. That demands exceed simply, for instance, taking her pills every day. We continuously come up with new gigs, new tasks, new errands that she and her family have to run. We're asking people like Maria Luisa to come with organized information, to ask prioritized questions, to record the clinical visit so that they can review later, to review the medical record for errors and inaccuracies, to use the portal to transmit data, to self-monitor, self-manage, educate themselves, manage appointments, prescriptions, bills, pre-authorizations, denials, delays, to overcome bias about identity, class, or diseases, advocate for herself and others. And of course, we're asking her to wait. Wait for that appointment, wait in the waiting room, wait for the clinician to come in, wait for the test to happen, wait for the test results, wait for the treatment. So wait, there's a pre-authorization you have to wait for, and wait, and wait, and wait. Waiting is the way healthcare tells patients, your time is not important to us, so please hold. Your call will be answered in the order in which it was received. This workload that Maria Luisa and her family have to face, they have to mobilize certain capacity to actually be able to shoulder it. Capacity that comes from a sense of purpose and meaning, from a sense of resilience and the ability to bounce back, from a form of literacy which exceeds simply understanding instructions or navigating the hospital signage, but actually also understanding when the rules can be broken, when is an empty stomach an empty stomach? I just took 2 pills. The third pill has to be taken on an empty stomach. Is my stomach formally empty, or should I wait? I forgot to take my pill this morning. It's now 11 in the morning. Should I take it today, or should I wait until tomorrow? And tomorrow, do I just take tomorrow's dose, or do I take double? That kind of literacy that gives you the flexibility to live your life while normalizing treatments into it. Of course, physical health and mental health will contribute to your capacity, financial health. It takes a lot of time to be poor. You cannot really hire additional help to support on your task, and many things require resources just simply to navigate through them. So if you are financially poor or relationship poor, your capacity to face all this workload is just your own. So when that workload exceeds your capacity, the way and overwhelms you, and you can't fulfill everything that you may have committed to do, our answer to that is to label you as non-compliant, or if we're nicer, as non-adherent, or if you're even nicer, as non-concordant. But in any way, we're labeling you, not your condition, your character, and who you are, as someone who cannot be relied as a partner in the self-management or in the co-management of your conditions. And this, when you're coming in for care, to be given a sticky label that other clinicians will get to know about and will immediately assume that they cannot help you, is fundamentally cruel. So a healthcare system that is supposed to care instead is processing people, changing the definition of what we decide is care to one in which we process people through as in a conveyor belt. This industrialized form of care sees patients as nothing but a blur, offers them generic and burdensome treatment, and is sometimes cruel. The form of cruelty that's most common in healthcare is indifference, which happens to be also, as opposed to hate, the real opposite of love. Without care, without proper care, healthcare is not sustainable. Not just financially unsustainable. 20% of GDP is not enough when you're not really caring for people. Not just environmentally unsustainable. 5% of the carbon footprint and the gas emissions are, just the beginning as healthcare continues to expand. And as we adopt AI, we're going to even have a bigger environmental footprint than we currently have. But also, and most importantly, humanly unsustainable. Only humans can care. And if our humans are overwhelmed and burned out, care is not going to happen. In this industrialized healthcare system, patients like Maria Luisa with multiple chronic conditions are reporting to us, 40% of them, that they are facing unsustainable burdens of treatment. That means they cannot continue with the current treatment indefinitely, and something will have to give. We're seeing such overwhelmed patients in clinical encounters in which patients, only about 40% of them, get to express the reason they're here. And that is because we already have an agenda for them with all the requirements that we as clinicians must complete in that same encounter. In fact, as we maybe pro forma ask them why are they there, we interrupt them now on average 11 seconds after they start talking. 11 seconds. That's one happy birthday. We learned that from COVID when we had to wash our hands with 2 happy birthdays for 20 seconds. And clinicians unable to make the time to see these patients, to connect with them emotionally and intellectually, to know who they are and to respond well to their situation, being asked to do something they cannot do, suffer moral injury, and eventually burnout, with 40% of clinicians intending to leave the practice or having already cut back their time to do more research or administration or some other tasks, or leave medicine altogether, which leaves, of course, the other overwhelmed burnout clinicians to care for the rest of the patients. So one number to remember, 40%. Healthcare without care is unsustainable. So how might we respond to this crisis of care? We have a couple of options. One response is to assume that this is a crisis of organization, of efficiency, of information technology, of scale. And we see a lot of our organizations working in these areas, trying to secure high-value healthcare by consolidating, bringing lean and other strategies for quality improvement, by seeking value through technology, by making big bets on AI. An alternative response is to assume that this is a crisis of care in and of itself, and that the solution requires attention to what care is. So what is care? Well, care is everything we do to maintain, repair, and improve our world so that we may live in it as well as possible. That world could be the world inside us, and that will be self-care. It could be the world of our families and our communities. It could be the planet. So care is arguably the most important thing that we do as humans in relation to ourselves and the people and environment that surrounds us. What we do in healthcare is a specialized form of care in which we try to improve the world of our patients, world that has been broken, fractured, or made confusing by disease and disability and distress and suffering, or the possibility of death. Another way of thinking about care is that it's a practice, a series of things that we do, and also a disposition to do them, a disposition to notice and respond, to notice that something is wrong, and that requires us to pay attention, to not be in our screens, but to look around and to notice, to be present, to understand the situation of the person requiring our care in high definition, not as a blur, not only in its needs, but also in what patients bring as strengths to the table that can be used to overcome their problematic situation. Noticing, empathy, not enough, because that situation needs to be improved in order for care to be present, or at least an intent to improve it has to be present. It's not enough to just notice and be saddened about it. We must decide to respond. It's in the decision to respond to that distress that we create the possibility that that situation can be improved. That invention of action, that possibility that we can do something about it, is what gives people hope. And it's also give and receive, care give and care receive. Caregiving is, in this case, to work with, not onto, unless, of course, you are, a trauma surgeon in the emergency department or dealing with a patient who is in a coma. But in general, it's working with people and showing up to that work with competence and with compassion, being able to intellectually bring possibilities and solutions to the table, but also attending to the particular emotional and personal issues that affect this patient. And it doesn't stop by showing up and just giving the care. Care needs to consider also care receiving. Was the response that we suggested or that we offered pertinent? Was it adequate? Was it desirable? And these things can only be decided not by JACO or some other external organization, but it can only be decided by the person receiving the care, in this case, our patients. So care is a practice and a disposition. It involves noticing and responding, and involves caregiving and care receiving as ways of making the world of our patients a place where they can live better in. Many of us have heard about the learning healthcare system and feel very proud to be part of the learning healthcare system and even do research in that space and become embedded researchers in the learning healthcare system. But that does two things that I find problematic. One, it places data at the center of what we do. And the second one, it eliminates from our consciousness the fact that the purpose of that learning healthcare system is to care. So when I was spending some time at the Agency for Healthcare Research and Quality, we work across the agency to formulate an alternative to that, which is AHRQ's Care and Learn healthcare system. And in this depiction, people are at the center, not data. And the process starts when the healthcare system and either the community or the individual patients come in contact. At that point, the healthcare system assesses, notices, and decides to respond with evidence-based practices by organizing people, information, policies, and resources. Now, the job doesn't end there. Because immediately after that, we need to evaluate whether that care was appropriate, hopefully with the recipients, as I mentioned before, to derive practice-based evidence from our experience and then to adapt that response so that the next person we see can get better health outcomes, better experience at a lower cost and with less burden to the patients and to the community and its economy. This system hinges on people's ability to engage, commit, participate. And so it stands in contrast with a learning health system in which data is at the middle and the processing of data, the transmission of information, and the manipulation of that information passes as care. This is a major risk as our organizations are increasingly enamored with the possibilities of algorithms and AI. And we must remind them that no matter how sophisticated, none of those systems are capable of care. Only people can care. And when they come together, either digitally or in person, the space in which they come together is the space of the encounter. This is my favorite sculpture, is by Rodin, and it shows two hands of two different people coming together, the fingertips almost touching, the hands leaving that sacred space in the middle. This sculpture is called the cathedral. And so that space is that space that makes a cathedral useful. And to me, it's a great image because it means that the sculpture had to remove everything between these hands in order for them to have that space to do what they needed to do. And similarly, in healthcare, we need to create the conditions, create the space for people when they come together for them to be able to care. And I think that the most important innovation in care that we can offer people that come together for care is the unhurried conversation. So I don't mean a long one. I don't mean a belabored one. I don't mean, exaggerating small talk. I'm talking the ability to kind of sit down and feel that time has been made, even if so briefly, for us to understand the situation of the patient in high definition, perhaps helped by, particularly in primary care, by resilient longitudinal relationships, and having appreciated that situation, work with the patient to co-create, to work together using shared decision making, a sensible resolution. A resolution that creates care that is maximally responsive to the problematic situation of the patient, maximally reflective of the patient's goals and priorities for life and health, and minimally disruptive of that patient's lives and loves. And so that configures care that fits each one of those patients. But it starts with creating the conditions for care, creating the conditions for unhurried conversations. Now, you will think that we will have a significant research program to try to understand how often healthcare systems create those conditions, how often are patients and clinicians meeting in unhurried conversations to form plans of care that fit. Instead, most of health services research works under this paradigm. There are some policies. Those policies produce some outcomes and some costs. We don't like those. We go back and change those policies. And that process continues, leaving the clinical encounter as a black box. And yet, when those policies have effects on that black box that we do not understand, effects that then convert into the outcomes that the patients experience and the costs that they incur. And we don't fully understand how is it that those policies produce those outcomes and costs, and we go back to those policies, we create a tsunami of unintended consequence to care. We create the possibility of these pathologies of care that I've reviewed with you, things like blur or generic treatments or burdensome programs or cruelty. We create industrialized healthcare. So care as the fundamental purpose of healthcare thus remains largely unobserved. When one looks at the medical literature, one sees very few examples of insightful direct observations of the clinical encounter. Here's one where standardized patients were brought in to see how clinicians with different degrees of burnout responding to their pain in advanced cancer. Here, they audio recorded the visits to determine the effect of the clinician well-being and burnout on diagnostic quality. Here, they video recorded general practitioners to explore how their workload affects their ability to deal with psychological problems that patients brought in. And our group did a systematic review of video recording of clinical encounters to determine what goes on inside the black box, only finding 175 studies. We have billions of clinical encounters, and we've only done 175 studies to understand what happens in care. So I think healthcare researchers must pry open the clinical encounter, must conduct encounter research, because care in the encounter translates a lot of that policy into care that fits, so has impact on each and every one of those patients, like Maria Luisa, and cumulatively translates into the health outcomes, costs, and burdens that we so worry about as we think about the macro effects of our policies on our society. Without prying that clinical encounter open, our picture is awful and incomplete. Think about the crisis of the opioid prescription use. When we found that there were these deaths of despair were occurring with prescription opioids, our response was to curtail the prescription of those drugs, which of course was initially fueled in part by the direct-to-clinician advertisement of these drugs, by the formulation of pain as a fifth vital sign, by the incorporation of this into the workflows of our electronic medical record, but without ever looking inside that clinical encounter and see how were those policies either to promote initially and then to detract from prescribing opioids will affect those conversations and how those conversations translated into prescriptions. We try to solve the problem without ever going to its roots. And the encounter is where we deal with the problematic human situation of patients, our core function, the reason we sign up to do this work. This is where we see how is the patient experiencing their situation. And this is where we also see how is the clinician responding to it, which is essential if we want to adapt clinical medical education and support for patients. If we want to be patient-centered and if we want to prepare our workforce for the future of patient complexity and multimorbidity. It is when we observe inside the clinical encounter that we find some surprises. So here is an observation of 100 encounters of patients with diabetes, in which we found that in 86 of them, there was some form or another of shared decision-making, which up to that point was considered incredibly rare in clinical practice. And we see not only that occurs, but that clinicians in some cases use even 6 different forms of shared decision-making within the same clinical encounter until they found the right one for this patient's experiencing this particular problem. There is a dance happening in clinical encounters, and we're not observing it. This is also a place for design. This is the cork floor in the Mayo Clinic, a cork floor that was put in the 1950s because somebody decided that controlling noise was important if we are to respect what is happening in those clinical offices. Those clinical offices that can be designed to remove distractions, to create, like that semicircular table, a space for collaboration and co-creation. A clinical encounter in which we can bring tools to help patients make that co-creation, that shared decision-making possible. And we can evaluate if those tools actually help patients make better decisions. I mentioned that the care unit is turning 20 this year. This is the first shared decision-making tool that we designed, and that QR code can take you to the website where other tools that we've designed are ready for your use and implementation to help patients co-create different plans of care. So instead of a black box, if we open if we pry open the encounter box, we might develop a much better understanding of the intended and unintended effect of policies on care and the effect that care can have on achieving outcomes and costs across the different kinds of patients and conditions and situations that we see in practice. It actually can affect that policy. For instance, when we see that we're trying to have careful deliberation and co-creation, and we can identify that, for instance, strong recommendation in clinical practice guidelines can act as a detraction to this, we might, like we did in this paper, ask for a moratorium on those strong recommendations until we better understand how they affect those clinical encounters. But also, as guidelines keep making more and more recommendations that are taking away from our time, we are asking guideline developers to think about the time needed to treat and beginning to do some estimates. For instance, one guideline recommending that we assess and do a brief intervention to promote physical activity is finding that it will take 15% of all of our primary care clinicians face-to-face time just to address that one guideline. There's no surprise that it will take a primary care clinician over 27 hours to do everything that is necessary for their patients. Nobody has been in the clinical encounter to ascertain the impact of those guidelines, and there is no feedback loop. So, what is a characteristic of encounter research? Well, it requires that we pay attention to people and the conditions in which they work. That means it is a profoundly social type of research, not one that you do behind the computer screen in your office. It's multidisciplinary. You want sociologists, and you want anthropologists, and you want designers, and you want clinicians, and you want patients to participate. It's participatory and it's direct. You do not want to do this through hearsay. You want to be in the room where it happens. And then you need to ask different and innovative questions. Is the care really careful? Is it responding to the patient's situation? Is it evidence-based? Is it provisional, leaving the door open for modification and improvement? And is it involving patient and a clinician in a participatory approach? Is the care kind, not nice, but is it maximally supportive of each patient? And is it minimally disruptive of the patient's lives and loves? And are the conditions for these kinds of care present? What is the culture of the organization? What are its policies? To what extent they favor or hinder care? Are the services responsive and simple and easy to navigate? Is the tech really adequate in support of that care? It calls into question the focus of our organizations on cures. I recently had cataract surgery on my left eye because of a trauma, and it was lovely to be processed through. It was pretty clear that I didn't need a relationship with my ophthalmologist, and my ophthalmologist, if he ever developed a relationship with my eyeball, it was really truly a situation of right person, right patient, right surgery at the right time, and I really wanted that outcome to be perfect. But increasingly, if I have developed a complication or if I have any of my chronic conditions, I am not on that side of this box. I'm on the other side where we manage symptoms, mitigate adverse effects, we cope with disappointing results, we prevent complications, we rehabilitate sequela, we provide self-management support, we provide problem solving, we make care fit. And in that space, for instance, most of my practice of caring for patients with diabetes, the basics of that are quite different. For instance, while on the surgery side, variance is a defect, on the patients with the care of my patients with diabetes, variance is a virtue. But our organizations cannot see that very well. They need to become ambidextrous. They need to become able to know when care and cure should be prioritized. And what should researchers do for this? Well, I think we need to focus as researchers on investigating and fostering the conditions for care, using innovative methods to achieve this. We must get into the clinical encounters to understand them, with a bias, in my opinion, towards intervention, so we can make those more hospitable to care and less hospitable to simply processing people. We must do it with others. We must be social. And I think we also must be political, because the conditions of care are not improving, they're deteriorating. We're increasingly industrialized. And I think I'd like to finish by inviting you to become parts of a movement that would promote care. This is the nonprofit I mentioned at the beginning. Take a look. We have over 120 fellows from 6 continents that are working to fundamentally change healthcare where they live and where they work. And in doing so, move us from industrialized healthcare to careful and kind care. Move us from those pathologies of care that I mentioned, blur, burden, hurry, cruelty, towards a healthcare that is capable of seeing patients in high definition, providing minimally disruptive care, supporting unhurried conversations that are responsive to people. And finally, I would like to invite you to our party, our 20th anniversary party of the Care Unit. We hold this annual conference. It's a small conference. It focuses on encounter research. It's about care that fits, and I invite you to participate and bring others along. I think with science and advocacy, by prying open the clinical encounter, by advancing encounter research, we can foster eventually for generations to come a healthcare that is based on solidarity and not greed, on integrity and not rules and regulations, that is not just efficient but unhurried, that is not for patients like this, but for this patient, that is minimally disruptive of patients' lives and loves, and is not based on transactional interactions, but is on relationships and interactions of love. Let's work together for careful and kind care for all. Thank you very much for your attention.
Thank you very much, Dr. Montori, for that very thought-provoking talk. The floor is open for questions, comments. Dr. Mirsky, I see you have come off mute.
Yeah, I just wanted to say that that was a remarkable presentation. And I think especially the care and cure sort of diagram you had towards the end. And so in my world, I'm a medical oncologist, right? So this is a very, very sacred encounter, and we need to find a way to make it so that it's not transactional, so especially this sort of tender relationship. So that was very thought provoking, and I really want to thank you for sharing that with us.
Very kind of you. Thank you.
Can you expand a bit on any response that you have gotten from payers around this model?
The response is probably similar to all the pre-authorization requests that you sent. Payers have not responded so far. It's we're 8 years into this work and this campaign, and there's an enormous resistance, I think, from the system and what supports it moving away from an economic and information model of care rather than a human model of care. There are a lot of efforts. Ours is by far, it's just one of them. There are multiple efforts to rehumanize healthcare, to help clinicians avoid or recover from burnout, from support patients everywhere, and we're not winning yet. I think that we can win. I think that we can make healthcare about care. It's one of those situations where everyone experiences, and we think very many people with a lot of power feel a sort of learned helplessness to solve this problem, constantly pointing up. I mean, it's interesting that you ask about what about them? What about the payers? I've talked to rooms full of CEOs and boards of hospitals, and what about them? I've actually been in a country in Europe where I was talking to the CEOs of the healthcare regions, and they were asking me, could you talk to the politicians, because those are their bosses. So we're constantly pointing upward, feeling disempowered. I think it's time for agency. Our patients think that we as clinicians are in charge. Clinicians think that administrators are in charge. Administrators think that the payers are actually in charge. And the truth is, we have to take responsibility. We're professionals. The trust of the population, of the people, depend on our ability to, or our willingness to act according to higher values. That's why I think my last line on what should researchers do is be political, not partisan, but be willing to engage with power. That's what be political means. Be willing to engage with power, take some risk, but do it on behalf of your patients, on behalf of care.
Thank you. We have a couple of questions and comments in the chat, and the first is from Dr. Khan, who is a retired primary care internist, who wonders if, to start shining light on the encounter's black box, would you agree that an initial step could be to remove or minimize the influence of for-profit insurance and medical empires from our relationships? And I think you just addressed that to some extent, and he wonders whether a universal comprehensive health insurance would address this issue.
Yeah, I think that's a matter of justice. I think the ability for us to live comfortably while some people are going to suffer dramatically because of inability to access and pay for healthcare is a tragedy, and it's intolerable. However, a lot of the attention goes into those things: access and pay for. And I think we also have to make sure that what they're accessing and what they're paying for is not simply the processing through of people, which then checks those two boxes without paying attention to really a care that is responsive to them. So we need to do all three. Give people access, make sure it's affordable, but make sure that it's care and not something that is passing for it simply because that's what we can afford. The second thing is, an intermediate step in terms of advocacy is to make sure everybody has primary care. I think a campaign for primary care for all is potentially one of the most insightful and powerful things that I've heard people promote. Because if everybody has primary care, even if you live in rural areas, even if you have very challenging personal situations, so forth, then it's much more likely that there will be a much more rational use of specialized and expensive resources, and there will be more resources available then to make sure that everybody gets covered. I think the idea of having universal healthcare that is heavily weighted on subspecialty care, one disease at a time, that now is also population health. So we are also doing prevention, one person at a time, is incredibly expensive. We need to promote a strong public health to improve the conditions of living for everyone, and a guaranteed primary care for all. I think our healthcare costs are going to go down, and our specialists, including myself, will be much better served by taking care of patients that are in fact benefiting from longitudinal relationships.
I think we probably have time for one more question, so we will do this one. Can you talk about how this approach can help restore trust between patients and healthcare?
Yeah, trust is very finicky, isn't it? I mean, once you lose it, it's very hard to get it back. And COVID, I mean, one of the biggest victims of COVID was trust, and not just trust with the health profession or with public health officials in particular, but also trust between each other. A society that is fractured, that cannot establish relationships of camaraderie and mutual support and mutual care, will probably demonstrate that in its institutions, including healthcare. So I am not surprised that violence in our society translates into violence in our workplaces. I'm not surprised that lack of care in our societies translates in lack of care in decision-making in our hospitals, clinics, and payers. So there is a fundamental need for us to reconnect as people, to recognize that we are part of a common experience. That phrases like the African Ubuntu come to mind, I am because we are, or like my home country of Peru, the Aini, that we are actually in this together. These notions of solidarity and mutual care are essential. I think in healthcare, the minute not only we say it in our mission statement, but we practice, we put care in the middle, we make care the core of what we do. We don't talk about value-based and evidence-based and patient-centered and focus in on those adjectives, but actually focus on care itself, care of each other as clinicians, care of each other as professionals, and then take all that healthiness that we get out of caring for each other to care for our patients, respond to our community's needs. I think that's how we basically first reconnect with our mission, and then show up with that professionalism to recover what we should have never lost, which is the trust of the community in us.
Thank you. Well, we are, I think, correct me if I'm wrong, E, right on time. And thank you to all our participants, but mostly thank you so much, Dr. Montori. That was just so thought-provoking. And I think as one of the many of us who will be heading off to clinic in 15 minutes, very rejuvenating and refreshing. So we have, I think, 3 of our fellows who will be staying on the line to have a little bit more in-depth discussion. And to the rest of the audience, thank you so much for participating in our Distinguished Speaker Series.
Thank you.